Hi, this is Dr. Ross Carter with the Medical Influencers Show. I want to welcome our special guest, Dr. Lee Tzanides. Welcome to the show today.
It's a pleasure to be here.
Thank you so much. So tell us a little bit about your background and how you got involved in. You're a specialist in regenerative medicine, correct?
Yes, I do regenerative medicine, pain management. I am also best described as a recovering internist after 30 years in that outfit. And I also was a former correspondent for NGTV, for National Greek TV. I was a medical correspondent for them for about 5 years, on and off. I also, I am a professor emeritus from my medical school in Guadalajara. I am also a police surgeon for NYSFOP, the District 997. I have also worked in Staten Island Hospital in internal medicine and in, a block right now, in substance abuse medicine, as well as in Ranexa Hospital.
Fantastic.
Well, that
sounds
being
like you
said,
have a lot of credentials.
A lot of credentials, and some time ago I also have a degree in molecular biology from Fordham. So that's where I had an interest in things regenerative when this opportunity was presented to me. So about 3 years ago, I started working for a facility called MoveWellMD. I am their medical officer, and we basically over there specialize in essentially physical medicine, rehabilitation, chiropractic, and we have on tap regenerative medicine where applicable. We combine pain management, physical medicine rehabilitation with chiropractic, acupuncture, deep tissue massage, and some basically physical therapy. So it's a combined facility, and we've met with some success doing it that way. Do a lot of migraine management as well over there. So that's, of course, before the world blew up, and now everyone's getting back on their feet from all this.
Excellent. And so what conditions that do you primarily work with?
Okay, in the facility, or are you talking about things regenerative?
Well, let's start with the facility.
Facility, we do a lot of, as I said, we deal with pain management, migraine management. We also deal with people who have any sort of musculoskeletal disorders, especially of the axial skeleton. So anyone who's got scoliosis, rotatory scoliosis, anyone who has trigger points, anyone who has any sort of discopathy, radiculopathy, do a lot of diagnosis of that. You'd be surprised how many people are walking around with chronic neck pain or chronic shoulder pain that they thought it was their shoulder, and when in fact it was coming from the neck. A lot of people with low back pain, lumbago is rampant, and the one thing that never ceases to amaze me is I've seen people who are former martial artists, people who've been physically assaulted, people who've been in car crashes, and then I have other people who come in with the same level of disc disease, and the only thing they say, "What do you do? Do you fight? Did you get into a car crash?" No, the main inciting thing with them is just that they use a laptop or that they sit in a computer and their workstation beats them up all day, and they get the same level of disc disease. That's an interesting thing I find all the time. See, because a lot of my folks that come in are stockbroker types. They're also people who work in offices. Many of these people have startups. Many of them are nonprofits, but they all have one thing in common: they use a computer. And the whole workplace violence. Computer-assisted workplace violence. It's basically they just eat up from their computers and everything. So a lot of times they just have them take a picture of their workstation and bring that in with them.
All right.
And that's, so you see the face of evil, as they say.
So you got involved in regenerative medicine how long ago?
About 3 years or so.
Got it.
I said I had answered an interview, and they were impressed with my credentials. And I always had an interest in that sort of thing. Everybody in pre-med wanted to be a chem major or a physics major. And at the time, I wasn't much into frogs and traipsing through the forest, but at this time, this had been offered to me. And it was a series of training that was basically geared to things more genetic. And I went through a series of courses that culminated with molecular biology. And a lot of this laid the groundwork of my understanding for what's been going on now. So at the time that in the 80s where they were experimenting with with recombination, they were using cellular fusion. They were doing things like making humulin, and they were using TPA was later invented. Many of these other things that doctors depend on every day. Much of these different types of medicines that are in existence came from genetic engineering and from things like Genentech and that company and other companies. So they were taking known DNA and they were inserting it via viral assist, phage, FX174, or other viruses into either E. coli or Candida albicans. And what they were doing is they were getting a clone of cells that would make you happy all day by making you artificial insulin. It would be making a protein from a sensitized lymphocyte. And indeed, most of what you're seeing on TV these days. So, it's kind of like when you have the baseball teams, you're going to introduce the opposing team first. Most of what you're seeing, anything with an MAB in the name of the drug, so it's a monoclonal antibody. So whether it's infliximab or bevacizumab or whatever you're seeing on, Xeljanz or Otezla or all these other medicines, I don't know if we're allowed to give, brand names. Most of these things come from a cellular fusion process where they're sensitizing a lymphocyte and they're fusing it with a myeloma cell. And if the clone takes, you end up with a clone of cells that is not a clone meaning a copy, a clone meaning a genetically manipulated, herd of cells. So that clone, it basically, all it wants to do for you all day is make monoclonal antibodies. So that's interesting. And I'm glad you kind of brought that up because that's an interesting segue into things regenerative. Mm-hmm. The major representation in big pharma and in the pharmacy industry up to this point has largely been wrapping their head around one element. So either it's tumor necrolysis factor alpha or TGF beta 3 or whatever it is, or interleukin IL-11A. So whichever one it is, they're wrapping their head around one factor that's causing inflammation in the body for arthritis, and they're making a guided missile that kills it. So, mm-hmm. So they're making this antibody that latches onto it and hopefully inactivates it. That's not a bad idea. Sounds really good in theory. Does work. Doesn't work 100% of the time. Then I want to make this parenthetic right now. Nothing, and I mean nothing, will work 100% of the time in medicine. Medicine is clearly not a plug-and-play science. It isn't an exact science. I had a professor in Guadalajara who he had quite a sense of humor. Mm-hmm. House had nothing on this guy, and basically they called him 8-ball because he had a bad leg and he walked with an 8-ball on top of the cane as his handle. Mm-hmm. The ochobala is what they called him. And basically, this gentleman, he had an expression. He said, "You want a guarantee in life?" He said, "Buy a dog that'll ask you to walk it every day, guaranteed. Everything else, it says this, all bets are off." Right. Well, essentially, it's a very well taken point when you think about it. I mean, all you have to show is just something above 17%, and they'll approve a drug, which is placebo even, right? And right. Show is something 17% or more, and you're there. So bottom line is a lot of things get approved, and parenthetically again, but I digress, 100% of the things on those late night ads, are you taking, Zeva Wonderful? I mean, 100% of those legalese ads, at one point, these were all approved drugs. So we have to be very careful of what we sign on for as doctors and, mm-hmm. and treating these various illnesses with these things. So essentially what you're doing with a monoclonal antibody is at least as far as arthritis and degenerative arthritis and inflammatory arthritis is concerned, mm-hmm. treating a inflammatory process by making an antibody against this substance that causes inflammation. But it's only one substance of many substances in the body causing inflammation. So for those that are a little more tech savvy, it'd be like hitting your F1 button 50 times when you turn on the computer. You're only pressing that and nothing else. Okay, there are many forms of regenerative therapy which are far superior in the sense that they're kind of like a Control-Alt-Delete. They're scattering the therapy across many different anti-inflammatory substances, they generally get a more evenly balanced anti-inflammation going on. And as a result, they have a different set of properties and a different set of things that you expect from them, and perhaps less side effects. Because when so say again?
Well, so you're saying that there are regenerative therapies that can actually go after multiple inflammatory markers. Is that correct?
That's correct. And as a matter of fact, when you're dealing with stem cells, that's really what the hope is. If you're dealing with either stem cells or certain Wharton's products, or you're dealing with exosomal therapy, all of these different therapies generally will ultimately have multiple inflammatory factors. Each one of these things has, or I should say that the stem cells will elute multiple anti-inflammatory factors. Your other ones are hardwired anti-inflammatory factors. The same thing goes for PRP. PRP is, of course, it's an autologous product. You're using your own platelets, and you're concentrating them about 5 times the normal concentration. And platelets, when they get super concentrated, they have their own hitting power, although not the same range and the same duration and so on. But they all work quite well. I mean, again, there are advantages and disadvantages to everything. I mean, the best example I give to people is this. So what's wrong with hitting the F1 button 50 million times? Well, if you're using a monoclonal antibody, you notice that the fine print of a lot of these drugs is that you may get a lymphoma, you may get a leukemia, certain cancers may develop. And the reason for that is it's kind of like right now somewhere in a salon, there's a girl, she's getting ruler straight bangs because she saw the latest edition of Vogue. And any young lady who's had that haircut will tell you that the bangs grow down at the same rate all the time. And any young man who has a broom-handled mustache will tell him that the mustache pretty much grows down at the same rate also. You try the same stash or the same haircut on the same person when they're about 45, 50, or 60, and you'll notice that right after they come back from the salon, everything looks right. And a few days later, they get these little extra hairs that are a little longer. And that basically implies dissimilar rates of cell division. And that belies a much more ominous concept below the surface. What's happening is you're getting a dissimilar rate of cell division by different, it's an aneuploidy, if you will. It's a dissimilar rates of cell division that's happening because you're getting cells of a certain herd that aren't dividing at the same rate of all the other ones. And these cells can have the potential to turn into cancer down the road. So the NK cell line is the natural killer cell line of your body. And these are kind of, basically they keep everything in order. They killed off the cells that have atypical markers that decide they're going into business for themselves. And that helps you to prevent cancer, which is a very sobering thing. After age, in each person, 4 out of 16 cell divisions will be atypical, go at the same rate, and you will have, a sort of, if you will, you'll have a sort of potential for cancer. So you wonder how we all don't get cancer at some point. So that's why I find that, that's why anyone who's a cancer survivor needs to think, and their doctor, think at least 3 or 4 times before taking a biologic. Mm-hmm. Biologics now that are approved for cancer survivors, and there are some that they say, well, you have to weigh the benefits and take it at your own risk. Regenerative, on the other hand, you do have to be careful about cancer, but now they're finding that certain regenerative products have anti-cancer properties in them as well. So I'm not advertising for people who want to get into it. And there's always the issue of hard data, but this is something that has been touted. We'll just leave it at that. And I'm not saying it's a definite. I'm not saying it's definitely not. These are all generalities, and the general public has to be aware of them. And these are things that, unlike what we're being told lately, do have to be taken between a doctor and their patient. You can't have somebody just saying a generality, do this, don't do this because I said so. Seems to be a lot of that going around lately. So unfortunately, I'm going to have to pass that back to the individual doctors, and somebody who's really trained in regenerative and understands this has to make these assertions and discussions, in the scope of a consultation with a patient, not, we're trying to give a general idea of what's going on. That's why each of these drugs has to be taken with its strength, with its weakness, like any other system that's designed and used like that. So as far as, so without that much more further ado, I want to talk about some different types of regenerative medicine.
Yeah, let's get into that.
Okay, in general, regenerative medicine is the science of tricking the body into healing itself. And that's right, I said tricking the body, because the body will heal sometimes it won't heal properly. Sometimes there's delayed healing, there's impaired healing. You may also have healing which occurs, but at a price of something else. I mean, the tissues of the eye, for example, are transparent and allow you to see. Any serious injury that occurs to the eye may repair itself, but at the expense of invisibility, which is why you see people who've been injured in the eye and they have these terrible white scars over the eye and they end up permanently blind, or they need a cornea transplant and so on. So healing isn't always a benevolent reparative process. Sometimes it's a fibrotic process. Sometimes it does heal, but it heals with scar tissue. Sometimes, there's there's a healing that may cause scarring, fibrosis, disfigurement. Kind of like the girl on Star Trek. They fixed everything, but they didn't have a pattern to go by, and she's kind of like this, So that's the same type of thing that happens. So how do we heal? What do we do? What do we offer? Well, the whole thing is that you're using the body to heal itself. The most basic thing that's out there now is PRP. So you're taking about 60 mLs of blood using a biologic centrifuge, which is an extremely expensive piece of equipment, and you're doing what's called a double spin. So you're spinning it down the first time for about usually around 3,800 RPMs, and you're doing that for about a minute and a half, and then the secret formula continues. You're taking off whatever plasma that's there, and you're stuck with cells, and you're taking a little bitty bit of the buffy coat off the top, which is of course where the platelets live. Mm-hmm. Bring that over to a second cylinder, and then you're spinning it down again for about 5 minutes at the same RPM. And this RPM, anybody who understands how a centrifuge works, these centrifuges are designed in such and such a way that the RPMs translate into gravitational force. So you're really hyper-concentrating the platelets. The best thing on the market now we're not trying to stay away from brand names and so on. The best equipment on the market now will give you a reliable 5x. So you're gonna get about, about 5 times the concentration reliably. Mm-hmm. You figure, what's your platelet count of 450,000 at max? So you're going to get 5 times that, which is 1 million plus, and you're going to get roughly that in terms of platelets. So why platelets? The platelets have alpha granules, and it should make perfect sense whether you're a creationist or you're an evolutionist that however those cells got there in your blood, it made sense that whoever put them there, they're not just for clotting, they also have properties of healing within them. So so your mother was right, don't pick the scab, and you let underneath that scab are all the platelets. And those platelets have alpha granules, which degranulate, and they release all of these healing factors. Many of these are pro-growth, some of them are anti-inflammation, and they cause healing underneath the scab. So if you're able to take these cells and concentrate them, and then shoot them into, let's say, a knee which is degenerating, the hope is that if there's a piece of cracked cartilage, you'll repair it. If there's a piece of cartilage that's worn down, it'll improve itself, and that's the theory. While you do get an improvement, it's never 100%. There's no such thing as perfect brand new assembly going on there. And PRP, the way it was taught to me was, it does works better when you combine it with, some other regenerative product. There is an entity called PRFM, which is basically PRP, but they add something to accelerate the clotting process. And you're basically injecting that semi-bloody serum into a knee and causing it to clot into a gelatin. And when you do that, you're doing a number of things. You're trapping those granules in the knee longer, kind of like Han Solo frozen in carbonite. Eventually gets out, but it stays for as long as possible, and it repairs as much damage as possible. When you're dealing with regenerative products, well, it's kind of the same thing. Regenerative cells or regenerative products eventually migrate out and find their way into macrophage-rich tissue. So if you're using this type of fibrin matrix, the PRFM as they call it, you're keeping it there as long as possible to do the most good. And essentially that allows stem cells to bookmark the damage and promote their healing factors as they do. And other factors will stay there as long and just keep them on station longer for the healing purpose. So that's what your PRP, your PRFM will do. So stem cells. All right. First, let's put some in the audience at ease. These are not fetal stem cells. These are not coming from dead babies. These are not coming from aborted fetuses. And quite frankly, you wouldn't want to, because you're buying somebody else's used car. The most successful, to save a lot of, going through all different types of stem cells, a stem cell, there are some people who used to use stem cells from fat, which is also known as SVF, or stromal vascular fraction. Some people used to fish around in the bone marrow to try to get stem cells. In Manhattan, as we speak, both of these things are not allowed. They're verboten, they're illegal, and this practice has ceased. Essentially, let's figure bone marrow. So you figure, well, if we go into the bone marrow, you're going to find stem cells, right? And the answer is wrong. You're not going to find stem cells, because in the bone marrow, I should say, your stem cells have long since left the building, along with Elvis. They're gone. You're not going to see them because those stem cells are pericytes. They are basically, they're not in, it's kind of like it's kind of like they're not in the headquarters of the stem cell. Those stem cell cells are basically the progenitors of very well-established cell lines that make your white blood cells, your red blood cells, and so on. And they're there, and they don't need the stem cells. The stem cells are actually out in the periphery of the body, waiting for some stimulus if they need to be helped. And, essentially, so if you're fishing around the bone marrow, let me just give you a quick set of numbers. At birth, maybe you've got 1 in 100 bone marrow cells as a stem cell. By age 2, you're talking about 1 in, 2 million? By age 7 or 10, you're talking about 1 in a million. By age 17, 21, and on, you're talking about 1 in 10 million. By the time you get to our age, you're talking about 1 in 100 million stem cells. So if you're fishing around the bone marrow looking for cells, I promise you're not going to find any. And the same thing pretty much goes for fat cells. They thought that because it was a vascular tissue, you'd have a better chance of finding it. Again, you're going to come up empty with that. So the cells that are the most successful stem cells are multipotent, meaning that they're not totipotent, they're not omnipotent stem cells, they're not the first cell in your body, but these cells can help a multitude of other tissue. And the way that they get these cells, they get them from generally a live birth. These are what's called, they're placental derived, is another way of saying it. So there has to be a volunteer. It's a live birth. The mother and baby have to be okay. They generally get this during a cesarean section, which is, as the crow flies, about 20% of all live births. So these are pretty rare cells to get and pretty rare patients to find. They're harvested at the moment right before they cut the cord. So this comes from a small pocket in the placenta on the fetal side of the placental apparatus. And the way this forms is when the egg is fertilized, it fertilizes in the fallopian tube. Everybody thinks it fertilizes itself in the uterus, which is not correct. So it bounces up and down aimlessly for a few days, and then around day 8, it exits the os into the uterus proper, and it slams into the wall of the prepared endometrium. And when it does so, at that point, you're dealing with a ball of cells, which is called a morula. So some of these cells fall off, and they become permanently trapped in this little pocket of fluid, which is about 400 cc's in a mature placenta. So they get a fair amount of cells to work with. And essentially, this would be like very much akin if you were hiking in some science fiction movie up in the Ozarks, and you find a bunch of pilgrims, and they're wearing the funny hats with the bell buckles, and they're shooting the funny guns that, flare open in the front, and they're eating turkeys and cooking bread and so on. And you go up to them and you say, "Hey, are you guys Americans?" And they say, "What's an American?" Because they were trapped in time. They didn't evolve into America. In the same way, a placental stem cell that's there. Some people call them day 8 cells. These are frozen in time in the evolution of that fetus before the HLA type 2 antigens, which is the white blood cell antigens that govern rejection, have had a chance to form. And as a result of this, these types of cells are basically, they'll pretty much play nicely anywhere you put them. So unlike our initial thoughts, we used to think in the old days was about 4 or 5 years ago, that the stem cell would go into a degenerating knee, and kind of like the painting in the Sistine Chapel of God touching Adam, it would touch the damaged cartilage cell, and kind of like the T2 Terminator, it would become the cell it touches and then just start fixing everything. Not the case. What happens is those stem cells go in, they have these little tethers called ligands, which kind of bookmark the damage. And when they're done bookmarking the damage, what they do is they will eventually migrate out of the knee, and they will end up in macrophage-rich tissue, which is lung, liver, and spleen. And from there, they start to elute these ECVs, extracellular vesicles, which we now know are exosomes. So some people are not understanding exosomes. Some folks think they're the work of the devil. Some people think that they're, essentially what an exosome is an exosome is a single or double membrane outpouching of cell membrane that's filled with a number of factors. And the number of factors are as follows. It generally, the exosomes that are for regenerative purposes, that is to say, they'll have your anti-inflammatory factors. They will have mRNA to make more factors. They'll have miRNA. That's correct. I didn't misspell it. It's miRNA. That is a switching molecule that takes your stem cells, wakes them up, gives them a hot cup of coffee, and tells them to get to work. And in addition to this, you will have also something very special. You'll have histone deacetylase, which is it's a very special chemical which will cause your DNA to uncoil and knock the telomeres off. So it's a form of telomerase, and it kind of makes your telomere age irrelevant. So this is what happens with these. And again, stem cells, the best way to get them is from a placental source. I mean, if you're looking to get them from your own body, as we get older, you're going to find a lot less of your own stem cells. If we've had cancer, chemotherapy, inflammation, radiation, any number of insults to the body, this all damages the viability and availability of these cells in your body. And please understand, a lot of this therapy won't work unless your own stem cells are relatively intact. I mean, if you're 90, 95 years old, you're kind of wasting your time. You're better off just getting shots of your own PRP and regenerative factors that are just coming literally out of a bottle, rather than trying to activate your stem cells and wake them up. But it does have its advantages. And again, there's stem cells that are coming out of placenta. There's umbilical cord tissue, which they say contains stem cells. I haven't found any yet. There's Wharton's jelly, which contains its own factors. There's amniotic fluid, which contains a lot of exosomes in it. And there's also combination types of therapies. Stem cells in and of themselves, they have some drawbacks and some problems. They'll take these cells out, they'll freeze them and preserve them. While they're vetting the mother, the baby, they check for about 57 diseases, make sure that they're safe, and then they make them commercially available to the doctors who want to use them. Problem is they're preserved with something called dimethyl sulfate. And the problem is when you thaw them, you get a fair amount of cellular death. So I'm not saying that anyone should take this to the bank, but as a rule, if you have 30 million stem cells, you're going to end up with 15 million going into the knee or wherever it is you're injecting. If you started out with 2 million, you're probably going to end up with about 1 million. And you have to at some point ask yourself credibly as a doctor, especially if the clinician is splitting, 1 ml of this very precious, elixir, and you're putting this in a knee and you're trying to get some in the ankle or you're getting it here. exactly how many cells are going in and what's going to be the viability of that clone you're injecting. I mean, you start, it makes you wonder. And the other question is, as far as dimethyl sulfate, they claim that this is a sulfite and that it's not going to bother people. You're allergic to sulfate, you probably shouldn't be taking this either. So there is a thaw effect. We talked about scaffolding. And the big covenant with all of this therapy, a couple of things apply with these therapies. There's a very big covenant that can't be broken with this. Any person who's taking these medicines cannot be taking any anti-inflammatories, so no NSAIDs. Can't be on steroid therapy, so you got to be off of it anywhere from 2 to 6 weeks, depends on who you talk to. Reason being, all of this therapy homes in on inflammation. So if you're taking an anti-inflammatory or a steroid, it's kind of like the airplane movies where the guy fires the missile and then the pilot on the other airplane turns off the engine and the missile kind of falls astray. It has nothing to home in on. And that's exactly what happens here. The other thing about being a clinician, a doctor doing this, is that the first thing you have to get through your head is that you can put these cells in places you would never put a steroid. Not even kidding around. I mean, you would never, say to yourself, would you inject steroid into an eyeball? Yeah. Ophthalmologists do it all the time for macular degeneration. Would you put any stem cell product in an eyeball? Never. You go blind because it turns into the Genesis weapon from Star Trek. It just, again, it heals, but it heals with no regard. It just blankets over with healed tissue, but it doesn't see. So that's why you had early reports of people going blind when stem cells were injected into the eye. Would you inject it into the brain case? Well, you can inject intrathecally certain regenerative products, but generally speaking, we don't inject stem cells there, okay? And yet there have epidurals happen all the time. They make a lot of people better. So again, there's this duality of where you can inject the steroid, where could you inject the stem cell, and the two never meet. What else can I tell you pretty much? I mean, that's as far as that's concerned. And then finally, as far as all of these different things are concerned, there's also protocols with these. Some of these are given in such and such a way. I find that the best protocols incorporate PRP or the scaffold form of it, which is PRFM. And generally speaking, they'll do it several times. My own personal experience, I've used this, on various patients, and I've had some decent results. You can't go when you're bone on bone, right? It's not going to regenerate cartilage to the point where you're literally bone on bone, and you expect the cartilage to regenerate like new assembly. I'd rather think about it as you're resetting a clock. So you'll improve your condition, but, and then that's as far as that. What questions do you have, Doc? I mean,
you covered so much information. There wasn't a lot of questions to ask. So you covered it very well.
I mean, I hope this helps a lot of people. It's as far as the other stuff is concerned, as far as my own personal experience with this, I did have some of this therapy done on myself. I did have some degenerative arthritis, and I had also some issues with torn labrum, torn rotator cuff. These things can be used in rotator cuffs. Some people claim that you can heal up to 30%. That I need to see the paper on. I was told that. I've never seen the paper on that. My own personal experience was I had exosomal therapy done, and I had a form of seronegative arthritis. I also had issues with my shoulders, with both knees. My shoulders are now 100%. My knees are now 100%. I had a thumb that was injected. That's 100%. But at the same time, everything degenerating got better, and yet my CRP didn't budge. And so when you're dealing with inflammation, everything becomes a math problem. Everything can be overcome. There are people who take, monoclonals, and they fail those types of therapies. So again, this is a very rapidly evolving science that holds a lot of hope for many people, and it needs to be pursued responsibly. It needs to be pursued with realistic expectations. This is not Star Trek. I always joke around about that. Maybe we're Captain Archer Star Trek, but it's not Star Trek. But we're getting there slowly, surely, and I think that the key is an open-minded approach to the profession and all of the branches cooperating with each other, not just the stem cell guys versus the monoclonal guys. And, you know, that's the only way we're going to help the patient.
Excellent information. So if somebody has questions and they want to reach out to you, what's the best way to get in touch with you?
They can call us through MoveWell. They can email us at info@movewellmd.com. They can also call us. Our outfit is at 150 Broadway in the Financial District. We're on Suite 1213, and the number there is 212-769-3210, and they can make an appointment for a consultation. And that's pretty much the best way. That's either that. I mean, we are on Facebook, but I don't participate in Facebook, and I don't answer Facebook questions. I am on LinkedIn. I can be looked up there as well professionally. And but like I said, if anyone's interested in any questions being answered or consultations or whatever, the best way is through work.
Perfect. Very good. Well, that was very informative. Thank you so much for your time on, elaborating on the different types of regenerative treatments that are out there. I'm sure many people have many questions about the different types. So I appreciate you taking the time to kind of go over those and explaining those.
Thank you, Doc. It's been a pleasure doing this with you, and look forward to doing this again.
Yeah. Thank you so much.